This is where I come from, Italy, Bologna in special way. I live here, and these two towers are tilted. This is not. This is important because we work a lot with tilted implants, and with a solution for prosthetic solution for tilted implants. I start from the beginning because before to talk about implant, I'm a clinician and I look the mouth in the whole aspects. So before to give a diagnosis to a tooth, I have to reflect which one is good and which one is hopeless before to extract it. And today I want to give you one more way to consider a tooth questionable that could stay. So a tooth is obviously eligible for extraction when we have endo lesion, severe periodontitis, fracture, loss of our tissue due to decay, combination of them, or irrational to keep when you have, for instance, 2 canine in the mouth, perfectly sound, but we can't do anything with it. Around the tooth, around the root, there are many important receptors that gives a coordination signals for muscles and for masticatory muscles. When we extract a tooth, all this information are lost forever. With implants, we don't have the same information that a tooth gives to the sensory system. Mechanoreceptors are very sensible within microns, and the periodontal ligament is not just a supporting tissue for the tooth, but it's a sensitive system. In our rehabilitation over implants, we don't have any of this. The patient can't control the force, the biting force. This is forever lost when we extract the tooth. So this action that we do before implant very easily today is irreversible. And today I would like to reflect about this option. Residual roots may serve as abutment for removable partial denture or overdenture for a temporary period, for a waiting that the patient is ready for the implant rehabilitation and can prevent bone loss. And this is the most important thing, I think. Let's see the practice. So this is a first aid solution, a very low budget patient, and I'm preparing this patient for the implant session, maybe in 1 or 2 years. But first of all, I give her a rapid solution. She has this partial denture with clasps, traditional clamps that fractured the crown. She asked me a solution, and the solution for me now is to put a ball attachment over the root, because I'm saving the periodontal ligament, the alveolar bone, for a longer time. So a proper endodontic root canal therapy avoid infections in the time. In the labs, the technician cuts away the clasps and put a new teeth. Endodontic post with a ball attachment is put in the root. And the prosthesis with an empty space under the tooth is glued and relined over the ball attachment. Now I have no more clasps, so the root has a vertical force applied on it, and this is physiologic. This is good for the root. The clasps move the tooth with horizontal and lateral force, as we will see in the next case. So we are saving we kept this patient in the studio, and we are saving it for the next treatment plan when we are talking about implant. This is the basic from where we start, but the patient liked it and asked the same solution for the others clasps. And now she's ready for a longer time, and the next step will be obviously implant therapy. This could be made at a higher level for patients that can't afford implant dentistry. They are not maybe eligible for surgery, or they have a very low budget. So before to think extract all the tooth, try to think this option. Even with more sophisticated or complex prosthetic solutions. These are the tooth mounted on wax, tried in the mouth. And I have, this wax is fixed on ball attachment, so it is stable, fixed in the mouth with the clip. So I can be sure of the two teeth position. The technician produced the Richmond with the ball attachment. And I'm rescuing lots of roots that otherwise I had to extract. The precision impression with coping cover, and with the information that I checked before, the technician can make the metal framework and maintain the teeth position to fix the resin and the metal framework. So this is a low budget but a high level prosthesis for the patient. Maybe the same case treated with implants would be very, very expensive. But he can afford a new social life that he still has. Why talk about roots? Because if we treat residual roots in some cases, in some patients that can't afford more complex therapy, we can save our work and do it better in a longer time. In this case, we have a root saved with a pivot, with a ball attachment. And in the other side, we have a normal traditional clasps that the patient didn't want to change it. After 2 years, the patient was ready for implants. Despite the poor hygienic conditions, this root saved a lot of bone around it. We can see better in the cone beam. Because we had a regular force applied over the root. We had no infections due to endolations because we practiced a good root canal therapy. In the other side, we lost everything. This is not a place where to put an implant today. We tried the tooth put in the wax, and this information is very important for the technician because I give it to the technician, and I give, after we will see how the correct position of implants that I put, and he can produce the definitive denture in 48 hours. In this chair side session, we start with surgery, so extraction of all tooth. This one was the premolar without bone around. And this was the residual root. Sorry for the light, but this was the residual root that saved a lot of bone around. So this could be a good place to put implants. And I have to thank the patient that allowed me to treat that root 2 years ago in that way. In this side, it was not possible to put any implant, but I needed it. It would be better if I put implant in the canine or premolar region. The precision impression these are the teeth that I checked before the surgery and filled the space where there were tooth with soft wax. This soft wax gives exactly the position of the implants. So the technician has the impression with the position of the implants, and this device allows him to put it in occlusion. He has everything facilitated by me, so he can run fast to make the metal framework and the counterpart that is filled in the resin. And in the next day, I can fix this definitive bar, because this system, this special system, has a new way of connection between the metal frame and the implants. It's, I put it without cutting because I'm sure that I have a precise passive fit over implants. We'll see later. I say now just that here, under this screw, I have a special plastic ring that eliminates any tension in the bar. And in 2 days, this is the big empty space left by the premolar. And this is the good bone quality that my root left. This is the definitive prosthesis that I delivered. I'm sure that in 1 year I need to reline it because I made many extractions. So I'm expecting a lot of bone resorption. But the job is finished. We were talking about tilted implants. Very often the residual bone alveolar, the ridge, the bone is tilted, and the only way to put implant is tilted. But from a prosthetic point of view, this is a disaster. It is the only surgical solution, but we need the technician and the surgeon must to look together, maybe the cone beam, to check if is it possible to put a prosthesis over this implant. If we cannot, this is a failed implant. Removable prosthesis works in a special way because when the patient applies the prosthesis in the mouth, there is only one path of insertion. He put it in the mouth, bite, and this is the only path of insertion. So our ball attachment, our final attachment to the prosthesis must be vertical. Some systems like ball attachment or equator can tolerate inclination till 15 or 30 degrees. Over 30 degrees, we have to make castable or customized solution. To respect the path of insertion of the prosthesis. This is important because we reduce the wearing rate of the ball attachment and we load the implant in a more correct way because the vertical load is is just over the middle of the implant now. If I have a ball right there, the load is out of the implant. The loading force is out of the implant. And horizontal lateral load in implants is very dangerous for bone loss. Everything is applied in the mouth, and we are with customized device. We are more vertical than with standard ball attachment, and this allows a longer life for prosthesis and for implants. Ready for a new life. This is a dear friend of mine. We work together. And here I would like to explain this kind of technique that allows me to apply the metal frame, and I'm sure of the passivation, because between this ball attachment that I apply over any kind of implant, I can put this kind of bar with another attachment to the prosthesis. This kind of device allows me to change it during the year. If the ball going under a lot of wear, I can change it, simply unscrewing it. This is not CAD/CAM. This is milled by a good technician. The sleeve is glued to the bar, and the attachment chain that I can change during the year is screwed over the ball. You can see here this empty space. This goes to the equator in the mouth over the implant, and the space between the two is filled with a ring, open ring, that goes exactly here. This is called Seeger. It's an open spring that allows to go under the undercut of the equator and stop and lock the bar over the equator. So the screw is just as a very small job. This is the Seeger that allows, is it a plastic device? So there is no metal contact between the screw that I'm putting in and the frame. So I have no tension. I don't need to check. I don't need to cut the bar and take another impression, give it to the technician for a new soldering procedure. Because this is open, and this gives the last assessment of the bar over implant. So I'm sure that I don't have any tension over implant. I have the perfect fit. This is why in the second day I can give him the definitive prosthesis. The screw just press the Seeger over the bar and over the implant. So the screw doesn't produce any tension because this butt joint goes over the Seeger, the plastic Seeger. Hygienical instruction for patients, as usual. I'm going very shortly, and I'm going to end. And talking about maybe unusual till now aspects of implant dentistry. But I think that now many patients we are going to visit to have a lot of patients that has in their mouth implants made in the 80s, in the 90s, that has broken prosthesis. So our job is not going only to make new implant prosthesis, but to remake old one. So we have to be prepared to this situation. Maybe in the 80s there were implant brand that does not exist anymore. So this kind of situation would be very common in the year. And to take away a broken screw inside an implant could be a very easy procedure if it is broken since a short time. But if it is broken since a long time and the patient didn't notice it can be impossible because of oxidation, calculus formation. So they are completely catched within the implant. When we have a broken screw, we have to follow a procedure step by step. First of all, remove all the coronal aspects. We have to look perfectly with a magnifier the aspect of the head of the implant. So with laser practice hemostasis, and visualize exactly what remains of the screw. If it's not possible by directly seeing it, X-ray are recommended. Then the first step is attempt removal with explorer. Sometimes it's possible to use two explorer, and move it counterclockwise. If it's not possible, vibrate with sonic scaler with thin tips, paying attention not to touch the thread of the inner implants. If I'm lucky, I'm able to vibrate it, and moving it counterclockwise, it will rise up. And then our session is ended. If it's not possible, I have to use this kind of device. If not, I have to drill it and make a new. If I don't use this device, I have to drill it and to make a new thread inside the implant. And this is a very difficult procedure. This kind of device has two kinds of burr. This has two claw, two arrows, and this works with very low round per minute, 5 rounds per minute, anti-clockwise. There is a good engagement between these blades and the head of the fractured screw. So I have to check the perfect contact between the burr and the head of the fractured screw. Using this centering device that has an internal hexagonal that allows me to put the burr exactly along the axis of the implants. Sorry, I ran. There is also an hexagonal external connection for external connection implants. The first burr with the two arrows is important to use at the first step, because if I'm lucky, it works and extract the broken screw. If the screw is completely oxided inside the implant, it makes the head of the broken screw completely flat. And this allows me to use the second kind of burr. I can use it even for the single tooth, obviously. In this case, we have an external hexagonal connection, and I had to use a customized driver because this was a 3.75 diameter. In this case, it was necessary to use the second burr, the cutting burr. I tried to use the first one, and it only turned the screw. It only made it flat. That it doesn't move. But this is useful for the next step, because I can use the centering device, and the flat surface allows the second burr to work exactly in the center, in the middle of the broken screw. It worked good because it made a hole inside, and then the contact between the burr, the cutting burr and the broken screw started to move it backwards. The final step is to use a handle piece and unscrew it with my hands. Repeat this procedure, washing, because this could generate heat, and this is not good for implants. So every 2 minutes or 3 minutes of drilling, you have to stop and wash it to put the temperature down. And the implant could be available now for a new life. I told you, this could be very common from now on, what to do with this kind of blades or implant. Not me, neither the patient were happy to take it away. I needed a solution to restore it. I can do it, and I can have a customized device that goes over my unknown implant, taking like a root canal impression. So I have to clean and dry the inner side of the implant, put a lubricated and clean with paper from the lubricant oil, and then put a polyether with a castable pin or something like this with the glue. And after the polyether has hardened, I can screw away this.